Welcome to Nurse Practitioner Week. The presenter for this session is Jana Esden, DNP, Advanced Practice Nurse Practitioner, and Family Nurse Practitioner. Dr. Esden is an associate professor at Frontier Nursing University. She graduated from Marquette University in Milwaukee, Wisconsin in 2003 with a bachelor's degree in nursing. She graduated from Frontier in 2008 with a Master's of Science in Nursing as a family nurse practitioner, and then with a Doctor of Nursing Practice degree in 2012. Her current research interests include chronic care, underserved populations, adverse childhood experiences, and trauma-informed care. In her clinical work, she works with a community clinic to serve patients at a transitional housing complex in Northeast Wisconsin. Her area of expertise is adults with chronic illness.
Hi there, I'm Jana Esden. Thanks for coming. This topic of ACEs is really interesting to me and also very important to me, so I take the opportunity to present on adverse childhood experiences whenever I can. I first learned about adverse childhood experiences, or ACEs, through my current clinical practice with a community health center in Northeast Wisconsin. My clinical work is with a population of homeless men at a transitional housing complex. So this is a satellite location for the health center. The organization is helping men to transition out of homelessness and into independent living. I also see a population of men transitioning from prison into independent living, as well as patients from a local warming shelter. So these individuals don't qualify to be placed at the local homeless shelter or in the transitional housing complex because they have current substance use or other issues. So I found out about this topic through working with this population, and I just think it's so important that I want to spread the word whenever possible. So learner objectives for the presentation include being able to identify the 7 categories of adverse childhood experiences, understanding the pathophysiology of how ACEs affect brain development in young children, recognizing health risk behaviors and adverse adult health outcomes that are associated with childhood trauma, and describing how to use universal precautions in implementing a trauma-informed care approach for all of our patients, and then describing how nurse practitioners can use primary, secondary, and tertiary prevention to reduce the burden of ACEs. So the original ACE study was published in 1998. It came off of a study on obesity. This was done by Kaiser Permanente with their HMO members in Southern California. They asked some interesting study questions in this obesity study, which clued them in that something else was going on. There were some questions about childhood trauma in there, and they found a pattern. So they did a full study on childhood trauma. This was a huge study with 17,000 people. There were confidential surveys on childhood experiences. They asked about current health behaviors, current health status, and then they took some objective findings like body mass index and things like that. So since then, a lot of additional studies have been published. They are all consistent with the original findings. And so the original finding was that at least 50% of the population has had at least one adverse childhood experience. But in other populations, a higher incidence was found. So this original study was Southern California HMO members. They have done other studies in higher risk populations and have found just much more prevalence and increased amounts there. So as I said, every study indicates that at least 50% of the population has experienced at least one ACE. So what they have found is that a graded relationship exists between the number of ACEs a patient has and their health risk behaviors and also chronic illnesses and mental illness. So they literally find a stepwise increase in 1 adverse childhood experience, 2, 3, 4, and the risk for all of these things goes up. It also increases their risk for early disability and also for disability and early death. So the consequences are broad. This definitely affects the individual, the victim, the victim's family, the community, and finally society as a whole. And there's definitely a lifetime, a significant burden, a lifetime economic burden of $124 billion. So the 7 categories of ACEs that they studied in the original study include the 3 types of abuse that we commonly think of, emotional abuse, physical abuse, and sexual abuse. There's also violence against a mother and living with certain people, living with a substance abuser, a person who has untreated mental illness, or living with a person who has been in prison. Now, in later studies, they've added some other things like, in particular, divorce, but these are the original 7 categories from the original study. So I guess the main question is, how do these adverse childhood experiences affect brain development? So when toxic stress is prolonged in a child, there's a strong activation of the body's stress response system. And this happens during sensitive developmental periods in the brain. These excess catecholamines and corticosteroids that are present during the stress response activation are damaging to the developing brain. So this changes the architecture of the brain, which influences future behavior, learning, and health. There's a continual fight or flight response that changes the brain at a molecular, a cellular, and a circulatory level. Even alterations in DNA are seen. So excess cortisol is very damaging to the brain. At the molecular level, it heightens anxiety and vigilance by augmenting this fight or flight response. At the cellular level, it exacts changes that reduce brain development and growth. And the cortisol alters the architecture of the parts of the brain that are essential for learning and memory. So this effect, what can we see from it? The long-term effects of toxic stress include impaired cognitive and academic functioning, as well as an alteration in emotional functioning and in behavioral patterns. So take a look at the pair of the PET scans on the right of the slide. The healthy brain is on the left and the abused brain is on the right. The temporal lobes are circled there for you. These regulate and process emotions. Compare the frontal lobes too. The one on the left is bright red, but the one on the right in the abused brain, it's so different. The frontal lobe plays a vital role for us in impulse control, our decision-making skills, in understanding language, processing emotions, our emotional regulation and expression, attention regulation, and it even develops our personality. So this toxic stress creates visible changes in the brain. So ramifications of ACEs, these health risk behaviors have been tied to adverse childhood experiences. Alcohol use disorder, drug use disorder, tobacco abuse, overeating, suicide attempts, and over 50 sexual partners. As you can imagine, those risky health behaviors also lead to chronic illnesses. So we see an increase in depression, heart disease, cancer, chronic lung diseases, skeletal fractures, and liver disease in people who have had a history of childhood trauma. Additional examples of consequences tied to ACEs include a disadvantaged socioeconomic status and less education. Well, that makes a lot of sense when a patient has cognitive difficulties and delays related to their changed brain, as well as difficulty regulating their emotions. So yes, they have increased difficulty maintaining employment, and they're much more likely to report poor health. I just want to do a couple of graphs here that show this stepwise increase in risk for health risk behaviors and illnesses that are tied to childhood trauma. So in every graph, although they are slightly different, you will see that the 0 ACE score, meaning the adult who as a child had no documented adverse childhood experiences, you will see that on the left, and on the right you will see the patients who have had the most adverse childhood experiences. So this is ACEs and tobacco abuse. Here's ACEs and alcohol use disorder. ACEs and IV drug use. ACEs and unintended pregnancy as well as elective abortion. ACEs and chronic depression. ACEs and mental illness in general, the mood disorders here such as bipolar disorder, anxiety disorders. This makes a lot of sense to me that this would have the highest prevalence considering the post-traumatic stress disorders in there as well, substance use disorders and impulse control disorders, and finally ACEs and suicide attempts. I'd also like to make a comment on ACEs and homelessness. So this is the population I see. we really need to be thinking about our patients' history, their development, how they were brought up, their childhood trauma when we're dealing with our most vulnerable populations. Patients who have had the most ACEs, are a third of them are homeless. So think about that when you see homeless persons on the street, or if you happen to be caring for a person who's homeless. There's a lot that goes into that homeless status. This isn't just simply bad decision making and nothing else. So the CDC has a great page on adverse childhood experiences. You can Google CDC and adverse childhood experiences, or ACEs, and you will come to a whole page. There's some documents there, including the original ACE study, which is available right there for you, and some other studies as well. They also have a nice little, I like this little chart here, this triangle chart that brings us from the original, adverse childhood experience all the way up to the early death and how they get there. This disrupted neurodevelopment, which impairs them socially, emotionally, and cognitively. They adopt these health risk behaviors, and then they have all these diseases and they die early. It's really very sad. So when we talk, it's good to know that patients may have a history of trauma, and we're going to talk about that in a little bit with the trauma-informed care. But we also need to talk about how we can try to prevent ACEs, because a lot of times, if you're caring for adults like I do, by the time they get to you, it's really too late. But we can, as nurse practitioners, practice primary, secondary, and tertiary prevention strategies to reduce the burden of ACEs. So primary prevention meaning stopping it before it ever occurs in the first place. So this is pretty tough, I think, because it starts with societal contributions, raising awareness of the detrimental effects, increasing social services to those in need, and things like that. Nurse practitioners can provide anticipatory guidance to families with young children to clarify normal development and to reduce unrealistic expectations from parents or caregivers of those young children. We can also advocate for families by assisting in enrollment in parenting classes and domestic violence prevention programs, or by requesting services such as in-home visiting for high-risk families. Now, at the adult level, one thing that I do all the time is I screen my patients for a history of ACEs. I ensure that they're treated for their depression or other mental illnesses, and I let them know they are at increased risk for continuing this cycle. So I have an open discussion with them about this in hopes that I can at least help break the cycle with their children by making sure that the patient is properly treated for any mental illness, has been through trauma-informed cognitive behavioral therapy, and being the supportive provider, as supportive as I can to my patient, and make them the best parent that they can be from my end. Secondary prevention of ACEs, this is really at the pediatric level. I don't personally see children in my practice, but a lot of family nurse practitioners, of course, do. So this is early detection of any childhood trauma. So we're building open and trusting relationships with our patients and their families. We're encouraging open communication, honest reporting of what is going on at home. We can also, of course, be vigilant at not just well child exams, but any type of visit looking for signs of abuse or neglect. Tertiary prevention is really what I do in my clinic. Now, with regards to the short-term tertiary prevention, nurse practitioners can respond to children and families who've experienced traumatic stress. There's a trauma toolkit for primary care that was developed by the American Academy of Pediatrics that's available. But really at the adult level, where I'm seeing patients who have had childhood trauma, we can appropriately treat resulting mental illness. We can refer our patients for trauma-informed cognitive behavioral therapy. Open communication about past childhood trauma in patients is encouraged, and it is therapeutic. Patients do not mind talking about this. If they have an empathetic provider who is honestly caring about their past experiences, talking about it is therapeutic. So we shouldn't avoid discussing that with our patients. We also play a very important role in managing chronic illnesses tied to ACEs. So we're the ones who are doing the smoking cessation, the substance abuse treatment, managing chronic illnesses such as COPD, hepatitis C, and heart disease, and all those things. So we definitely play a huge role in tertiary prevention of ACEs. mitigating those negative effects. So what is a trauma-informed approach? So, you don't know which patients of yours may have a history of multiple ACEs. You may not be able to recognize who is at risk. So we know universal precautions as, bloodborne illnesses and treating every patient like they could have, a bloodborne illness. Well, in this case, universal precautions with regards to a past history of trauma. We need to make sure that we are thinking about this not only when we talk to patients, but also when we think about what they are doing for their health risk behaviors. For example, he continues to drink alcohol against medical advice, or her BMI goes up at every appointment. I'm sure a lot of you have heard similar comments to that from providers. Providers do get frustrated when patients' weights go up at every appointment, despite their best efforts for helping the patient to maintain a healthy weight or lose weight and get out of that obesity status or morbid obesity status. Well, we need to think about how sometimes those behaviors to us, that's a problem, right? Drinking alcohol, we consider that to be a problem, okay? Or overeating and being obese, that is a problem to us as healthcare providers. But we need to think about the fact that to a patient with a history of childhood trauma, that could be the solution. Okay, so if you have a patient who has a history of significant childhood trauma and they have untreated PTSD or another anxiety disorder and they drink alcohol to mitigate their anxiety, that's their solution. Okay, if you have a patient who was sexually abused as a child, and she has figured out as an adult that when she is overweight, men do not pay attention to her, that is her solution. So we can talk to patients as much as we want about reducing alcohol intake or losing weight and caloric this and exercise this much. But if we don't get to the root of that problem, of why that patient has that issue, then we are never going to get anywhere, okay? Same thing with procedures, okay? She's no-showed for her PAP appointment 3 times. She needs to be discharged from the practice, okay? Or he continues to cancel his dental appointments. He's non-compliant. We need to think about how some of the procedures that we do in the healthcare field can trigger patients with a history of childhood trauma. So this is what I call putting on your trauma lens, okay? Put on a trauma lens and think about what it would be like to go to a dental appointment for a patient who has a history of child sexual abuse. Lay back, open your mouth, don't talk. I'm going to put this heavy weight on your chest for your x-rays. That can really trigger patients, okay? And they can't handle it. They don't want to do it. Same thing with the PAPs, of course. That's a very sexually invasive procedure. I mean, it's right. Some patients they just can't bring themselves to do it. They know they should, but they just can't do it. So if I have a patient who has canceled appointments, I talk to them about that. Now, I see you've canceled, your physical 3 times. Do you want to talk about that? Is there something that I can do to make you feel more comfortable? Is there anything you want to tell me that might be interfering with your ability to come to this appointment? Okay, so in my clinic, we have a trauma-informed approach. Okay, not only are we moving to fully integrate behavioral health into our clinic, where we have counselors available, therapists, all the time, everywhere, for anything that's needed. If somebody is needed over in the dental area for a nervous patient, they will head over there. If somebody comes in and needs to be seen immediately, they pop right in the room. That's what we're going towards at my community health clinic. In my tiny satellite clinic, all new patients do get an ACE questionnaire. So this is the questionnaire that came off of the original study. They follow up with a discussion with me where I ask them specifically, about their childhood. That is not the first question I ask them. It is a very intense interview that this is towards the end, so it's not my first question out of my mouth. But I do talk with them and make sure that the ACE questionnaire is accurate, because they're coming in as a new patient. They may not be comfortable talking about that or circling it on the form. But what I will say is, if for any reason you decide to do these forms at your clinic, you need to make sure that you are following up on them. If a patient is going to open up to you and circle physical, verbal abuse, violence against a mother and a father who is an alcoholic, or the right alcoholic or some other substance use disorder on a form, you need to be ready to talk about it with that patient and not just put the form aside and pretend it didn't happen, okay? So, but in my clinic, yes, every new patient gets the ACE questionnaire, they follow up with me and we talk about it. I talk to my patients about how their childhood has affected their adult life, okay? That it did affect brain development, and I'm going to do the best I can to help them to, you know, have a normal, productive life. And but I let them know that although they're responsible for their own decisions, that this had an impact. Okay, I screen them for anxiety, for depression, for substance use disorders. I strongly encourage them to go to trauma-informed cognitive behavioral therapy with one of our counselors. I continue to build an empathetic and a trusting relationship with them over time, and then I go to work on their chronic illnesses, and I do those tertiary prevention strategies, treating the chronic illnesses, treating the mental illness, and of course treating for substance use disorders. So conclusions for me is mostly to know that this affects patients in their adult lives. We can't just tell patients to leave the past in the past, to get over their bad childhoods and move on with their life, because the brain changes remain, and it has affected them throughout their childhood. As they move into adulthood, it affects them socially, it affects them academically, it affects them in all areas of their life. So this toxic stress, unfortunately, once you get to the adult stage, like I said, I'm dealing with them after the fact, can't do anything about it. But a lot of them have never even been told that this could have affected them. Nobody has let them know that their anxiety, it's okay to still have anxiety from those childhood experiences, that they don't need to just get over it, but we're going to treat it. Okay, ACEs have lifelong ramifications. They can be mitigated, but there has to be a trusting healthcare provider in the mix. We need to implement trauma-informed care strategies and really be putting on that trauma lens when we're in the clinic. We play a very important role in reducing the burden of ACEs. If anybody has any questions, I know this is previously recorded. I'm happy to answer your questions via email, Google Hangout, or on my office line. Thank you very much.